Okay, so the next thing to consider would be if somebody comes in with shortness of breath and you've asked about duration and it's just a few days long. Usually this is not very acute. People can have very acute shortness of breath if they have a lot of tachycardia with palpitations, and if you're considering atrial fibrillation or supraventricular tachycardia. But AFib patients, if it's mild, they can have symptoms for a few days duration. So anywhere from several hours to a few days duration, they have palpitations. Typically, because of a lot of palpitations and a lot of irregular flow, they also complain about nausea. So don't be thrown away by nausea. This is a GI symptom, but the point here is that this can also be present in the setting of AFib or SVT. So patients, why do they get palpitations and why do they get shortness of breath? Well, that's simply because they have a very irregular heartbeat, and at any given moment, the heart is not given any opportunity to fill appropriately and eject appropriately to oxygenate the entire body. So that is why they start developing shortness of breath. So regardless, your shortness of breath and palpitations combination should lead you to think that it could be AFib. And obviously, as soon as you look at the vitals, you will see that there is some tachycardia. Also, again, there are other risk factors for developing atrial fibrillation. So these patients, usually older population, again, people older than 70 very easily can develop AFib. I don't know why, but they do. Younger population has a history of alcohol heavy use, so heavy alcohol use can cause AFib. Hyperthyroidism or hypothyroidism both can cause AFib, usually hyperthyroidism more than hypo. And then history of pulmonary disease that can cause hypoxia and cause the sinus node dysfunction and eventually lead to AFib or SVT. So this is how we if we identify any of these risk factors, or whenever we are taking history, when we ask any of these things and these are present, then we can say, all right, maybe this patient has AFib. But again, it is a very easy diagnosis to make, but you will make this diagnosis only if you think about it, right? So anybody who comes in with tachycardia and you don't even think about AFib, you'll probably not do an EKG to look for it. So therefore, it's important to think about it, and in the setting of shortness of breath with some risk factors. So what are the physical exam findings? These patients usually have an irregular pulse. So whether or not they have tachycardia, they should have irregular pulse. Regular pulse excludes AFib. So that's just something to keep in mind. Tachycardia usually is present in the setting of symptoms. If there are no symptoms, then maybe it is a rate controlled AFib and they have a normal heart rate, but they still can have a regular pulse, and usually they don't have too many symptoms. So that's how you kind of know that this is a symptomatic AFib. So this is just the point to say that heart rate is important to look at. Heart rate is also important because that decides what we should do in terms of management. So the next thing, the diagnostic test to do would be EKG. Again, very easy diagnosis to make. We do the EKG and the hallmark would be absence of P waves. If the P waves are present regularly throughout the EKG, then maybe it is not AFib. There may be some irregular P waves, there may be some erratic P waves, but you should not see regular P waves in EKG. And the troponins can be drawn to see if AFib is causing some myocardial ischemia. You may see some leak, but usually you will see normal troponins. Treatment of AFib is very interesting and important to. Before treatment, why do we even worry about AFib? Why is it important to recognize it and treat it? Well, because this is the most common or a very common cause of stroke because of infarction. So one of the biggest reasons why people get cerebrovascular accidents in the form of infarction, not hemorrhage, infarction, is because there is a blood clot that's coming from the heart because there was AFib and the blood was coagulating there. So that blood clot goes to the brain and causes stroke. Very common in older age. So the treatment is very important and interesting because what we do is we primarily focus on rate control, because we have seen that if tachycardia is controlled, then usually these people have no symptoms at all, and usually they don't develop blood clot very easily except in certain situations, and we'll talk about that here in a second. So rate control with beta blockers and calcium channel blockers and rhythm control only if patient is hemodynamically unstable. So we'll control the rhythm only if the patient is hypotensive and hemodynamically unstable. Only then we control the rhythm, or we convert atrial fibrillation into sinus rhythm. But otherwise, you don't have to control the rhythm. Anticoagulation is important. And why do we anticoagulate these people? So we don't always anticoagulate everybody with AFib. There are plenty of people who have AFib, especially your younger population with a history of alcohol use. So they may have transient AFib. You don't always anticoagulate. So there is a criteria for that, for anticoagulation, and you all know. I think you are familiar with it. So there is CHADS 2 score that we use, and CHADS stands for history of heart failure, so congestive heart failure, hypertension, age older than 70 or 75, older than 75 actually, and then diabetes, and then history of stroke or symptoms of TIA at the time of the presentation. So that's why there's two S's here. So congestive heart failure, hypertension, age, diabetes, stroke, or symptoms of TIA. So whenever the score is more than 2, we usually anticoagulate them with warfarin or Coumadin. If the score is 1, then you can just simply use aspirin. If it's higher than 2, of course, then you will do warfarin and Coumadin, and if it's even much higher, then you can convert them and do some treatment on those lines. So alright, so this is a slide showing an EKG. So you can see that there is a very irregular pattern. So you can hardly see a pattern here. At first glance, when you just look at the EKG, you just see some small abnormalities, but when you pay closer attention, you can see the P waves are virtually absent. There is a lot of irregularity. Some waves that may appear to be P wave are actually not P waves because they are not regular. They are very different morphology every time you look at them, so therefore the P wave is absent. You can see that in this particular EKG, the irregularity of the heartbeat is not really that remarkable. So this may be confusing for some people because it's not really that irregular. You can see there's a fairly regular rate at least, but as soon as you start looking for P waves, they are absent. So that's how you know that this is AFib, and the rate is here. The rate is not really that tachycardiac, so that's how it's important to distinguish between AFib and a normal EKG. Next is our pulmonary causes of dyspnea. So this is now we're done with the cardiovascular causes, which were quite a few. So again, almost all cardiovascular causes of dyspnea will show that the patient has more shortness of breath when they're laying down. That is a distinguishing feature. Now we start talking about pulmonary causes. So the first question will be, of course, duration and onset, and if the patient is accompanying wheezing and shortness of breath. So of course, surprisingly or no surprise, these patients have exacerbation of either asthma or chronic bronchitis or emphysema. So you are all very familiar with these symptoms. Whenever you have a combination of these things present, then you think about either COPD, chronic bronchitis, emphysema, or exacerbation of asthma. Now these patients can present with regular stable diseases, or they can come in with exacerbation, either or. And if it's exacerbation, like we discussed earlier, it may signify a red flag situation. So that is why it's important to look at the vitals. So the next, logically speaking, the next good question after chest pain would become wheezing or cough along with dyspnea. And if the patient says yes to this, then start thinking about these diagnoses. And of course, all these three, when they become really, really severe, then we call it COPD. Additional symptoms would be that these patients may have some phlegm. So especially if it's chronic bronchitis, they have more phlegm. If it's asthma, they have more wheezing. If they have in the past 2 years, if they have more than 3 episodes for 3 months, then that is technically speaking chronic bronchitis. If these patients in the past responded to inhalers, then also that's a big clue that this is probably either chronic bronchitis, emphysema, or asthma, because other causes of dyspnea and shortness of breath don't get better with inhalers. So for example, cardiac patients, they don't get better with inhalers. They may actually get worse if they use beta agonists, because they now become more even tachycardiac. So that's how you can differentiate. Risk factors again, so just like anything else, these patients usually have prototypical risk factors, so they are not going to just come in out of thin air. They usually have a history of smoking. Heavy smoking will cause this. Family history of asthma, and usually a history of allergies. So younger population with history of allergy, polyps, so they can show with asthma, or alpha-1 antitrypsin deficiency in patients who are even younger, and if they have a family history of alpha-1 antitrypsin deficiency, they can show up with emphysema. So another very important thing to keep in mind. And usually, unfortunately, this is a very severe form of emphysema, so very hard to treat it. Physical exam findings or signs would be these people can have a hypoxia. So if they do have hypoxia, of course we gotta intervene at that time. They may need oxygen right away, usually low flow oxygen, and they need nebulization treatment. So it's very important to recognize that red flag. They may have a little bit of tachycardia, but usually not bad, and usually their blood pressure is stable. On lung exam, they have wheezing, so very, very profound finding. If you hear wheezing in both lungs, then it's usually it's a hallmark finding of either asthma or chronic bronchitis. They may also have rhonchi if they have superimposed inflammation. Sometimes they have decreased air entry in one or the two lobes or the two sides, and they also can show pulsus paradoxus. So pulsus paradoxus is a classic feature of status asthmaticus, so that is something to keep in mind. If you see pulsus paradoxus, then you gotta look for or treat status asthmaticus. So very important thing to keep in mind. There are two categories. So in textbooks, these are textbook pictures of blue bloaters and pink puffers. We see them sometimes, but they're not very commonly presenting pictures. So people don't always show up as blue bloaters or pink puffers, but if they do, then definitely this is a significant finding. So blue bloaters patients are usually more chronic bronchitis patients. They are like the name suggests, they are bloated, they're a little bit more congested. Pink puffer patients are usually thin, they have barrel shaped chests, and they are emphysema patients usually. And then the treatment, again, nebulization treatment. So even with less than red flag situation, even if it's not very severe, whenever they come in with significant symptoms, we gotta give them nebulization treatment. So that is something to keep in mind. You may need to do spirometry as a part of the treatment or as a diagnostic test, because this way you know what the lung function is. That is usually spirometry can be done in office, so it doesn't have to be sent to a specialist, but and it gives you a very quick picture, and so it's not a very long procedure. Chest x-ray can be done to give some to get some idea if the patient has developed pneumonia on top of bronchitis, or has emphysema, or has any complications because of asthma. So chest x-ray is important in that regard. PFTs are the tests to do after the acute episode has resolved. Usually we don't do PFTs right at the time when the patient is having an acute attack, because you got to stabilize the patient first. And when you do the PFTs, you all see very classic readings on those, and you're already familiar with that, so I will not go into the detail. Management. So asthma classification is extremely important. We gotta be familiar with the classification. So there's mild, intermittent, moderate, persistent asthma, then there is severe persistent asthma. So there are four classes of asthma. So I know you already know about the classification, so go ahead and review it, because it's important to be able to classify asthma based upon either mild, intermittent, mild persistent, moderate persistent, or severe asthma. Based upon the number of symptoms and based upon the frequency of symptoms and episodes, we categorize our patient into one of the classes, and that's how we titrate the treatment. So go ahead and review it again if you can, please. This is just a slide showing that all three of these things can turn into COPD when they become severe. So basically COPD means that based upon the GOLD criteria, based upon the severity of symptoms, it can be from very mild to very severe. So very mild would be where FEV1 is more than 80% predicted, and the ratio is less than 70. Very severe, if you go down on the severity level, very severe would be when your FEV1 is less than 30% predicted, or FEV1 is less than 50% predicted plus chronic respiratory failure. So that's how we basically classify from mild to moderate to severe to very severe COPD. So it's not asthma classification, it's COPD classification based upon spirometry findings. So you are already familiar with this, so just go ahead and review it again, but this is how we classify. This is a chest x-ray showing some interstitial markings, and there is hypervascular markings along the lung linings, and you can say that this patient has fair amount of inflammation going on. So this is your COPD patient. This is a PFT, and you can see that normal loops will look like this, and there is, if it's an obstructive pattern, then the FEV1 is markedly reduced, and the restrictive disease it's not as so you can look at this and again review it. You're already familiar with it, so I'm not going to go into the detail on the spirometry here. Again, some loops showing your COPD, obstructive disease, your restrictive disease, your chest wall disease, and normal pattern, so you can review it again. Next is the pharmacological and non-pharmacological treatment of COPD. So pharmacological is as important as non-pharmacological, of course, so they're both very important. We prescribe bronchodilators, extremely important for rapid rescue. We can also do steroids. Usually in exacerbation we have to do steroids, and then antibiotics are usually given if there is superimposed infection. Usually these patients will need some antibiotics, especially your chronic bronchitis patients. Non-pharmacological treatment will basically rely on the bedrock of these things. So smoking cessation, of course, not surprisingly, is the biggest thing. They have to stop smoking. Unfortunately, smoking addiction is so severe that people don't quit smoking easily, but if they can, it will make a life of a difference. Mucolytics can also be prescribed, so those are just basically used to help with the secretions, because these patients usually have a lot of secretions. Pulmonary rehab in the form of breathing exercises can help. Positive pressure ventilation or BiPAP can be used. This can be given in the home setting, so patients don't have to be hospitalized. This provides extra pressure for ventilation and helps with better oxygenation. And then pneumococcal vaccine or pneumonia vaccine is a preventative thing that we do for our COPD patients, because these patients are at high risk for developing pneumonia. Then there are additional diagnoses that can present like COPD. So for example, your bronchiectasis patients, your cystic fibrosis patients, those are not as common as the other three diseases that turn into COPD. So briefly speaking, these patients usually, cystic fibrosis is usually a younger age diagnosis, and you already know this. These patients usually have failure to thrive. They have, in addition to respiratory symptoms, they have gastrointestinal symptoms, and the sweat chloride test will be positive for them. Bronchiectasis patients usually have chronic cough and phlegm and infection, and they have all these things at a younger age again, and they just keep on getting these bronchitis starting from younger age, even in the absence of smoking or risk factors. So that's how when you evaluate them, you know that they have permanent dilatation of the distal bronchioles, and you know that this is bronchiectasis. So very unfortunate scenarios, both of them. The life expectancy is usually low with cystic fibrosis, so it's really hard to treat both of them, but of course you can manage them. Next is again patient coming in with dyspnea or shortness of breath of acute duration, and usually they don't have any preceding history like we noticed in the COPD cases. So, but if they do have productive cough, then another diagnosis you can think about is pneumonia or bronchitis. Usually pneumonia is more severe form of infection, and then bronchitis is less severe. Pneumonia is the infection of the parenchyma, bronchitis is the infection of the airways, and pneumonia patients usually have fever as well, and bronchitis patients usually don't develop fever, but they both have productive cough and shortness of breath. So on top of that, the productive cough will be green phlegm. So usually they don't have just a clear phlegm, because clear phlegm is usually a sign of either allergic bronchitis or upper respiratory infection. But if it starts to turn color and now it is green or yellow or brown or whatever the color they want to describe, but it is opaque, then it could be a sign of either bronchitis or pneumonia. If the pneumonia is in the distal lobe, then they may not produce too much phlegm, but they just have a whole lot of cough, which is pretty wet, and on top of that they have fever. Usually these patients don't, of course, have a history of asthma or inhaler use, but of course a patient with COPD or asthma can also develop pneumonia. So in that case, this is still a possibility. And surprising or not surprisingly, these patients with asthma or COPD are at higher risk for developing pneumonia. That is why we should always think about these diagnoses. Whenever their baseline symptoms progress to get worse and now they have much more productive cough and shortness of breath, then obviously do rule out pneumonia bronchitis. Risk factors, again, in patients who don't have a history of asthma or anything like that, their risk factors would be very young and very old patients. So your children and your older nursing home patients are at very high risk for pneumonia, so definitely check them. Patients with recent upper respiratory infections usually can develop pneumonia. They can develop staph pneumonia, so that is important to recognize too. So people who are just not getting better, you saw them with upper respiratory infection, they came back after a few days and you had told them to just relax, it will get better. Now their phlegm is turning into green and they're developing fever, then of course not only they are upset, they also have pneumonia. The physical exam findings would be that these patients can have tachypnea, so the respiratory rate will be high, they may have tachycardia, and again, if they have hypoxia, that's a red flag situation. Make sure that you take care of it. They may have fever, and on a lung exam they may have some rhonchi, they may have some dull percussion, so just keep that in mind. Especially if it is a lobar pneumonia, which is usually streptococcal pneumonia, on that side of the lung your percussion will be dull. The test of choice would be chest x-ray, and you can also do CBC to see the extent of the infection and also for monitoring the response to the treatment. But the chest x-ray will give you the idea. X-ray will show if there is any pneumonia or not. Bronchitis patients may have a very normal chest x-ray. So this is a chest x-ray showing right lower lobe pneumonia. There is a lot of consolidation and there is some parapneumonic effusion too. And there is another chest x-ray showing right lower middle lobe pneumonia. You can see there is a pretty good consolidation, but there is no effusion. So this is how chest x-ray will look like. Another x-ray showing right upper lobe, so there is a lot of consolidation right here, so there is a pneumonia on one side.